Hi, and welcome to SpondyCast, where we bring together the best medical minds, thought leaders, scientists, patients, and caregivers to inform and inspire the spondylitis community. I'm your host, Jill Miller, living my best spa life, knowing that how we meet today has the power to change everything going forward. Hi, and welcome to SpondyCast. Today, our guest is Dr. John Reveille, professor of rheumatology at the University of Texas Health Science Center at Houston. He has 46 years of experience in the rheumatology community, and he is going to join us today to talk about medication options for the treatment of spondyloarthritis. He is also a very valued member of the Spondylitis Association of America's board, and I am grateful for his time. Dr. Reveille, how are you today?
Very good. By the way, I've actually been on the board since 1987.
Wow.
I was on the very initial board.
You've added a lot to this community, I have no doubt, through that work and all your other work. I was easy on you with the bio, so I didn't go into the deep details. But you have a lifetime of working with spondyloarthritis patients, and we're going to talk a little bit about medication today, which is one of your favorite topics, I know. So let's just talk really quickly. The definition, or what is spondyloarthritis and common symptoms?
Spondyloarthritis is an inflammatory disease that affects the spine, but also other parts of the body, such as the joints. The entheses is where muscles and tendons attach to bones, the eyes, and in some patients, the skin, the intestines, and the heart and lungs.
And what are the current medication options for patients out there for treatment of spondyloarthritis?
Well, I think leading the group of medications are the non-steroidal anti-inflammatory drugs, NSAIDs. Two of the most typical over-the-counter ones you'll encounter, for example, would be naproxen or ibuprofen.
Sure. I've seen a lot of bottles of those in my lifetime. What are you hoping to achieve when you do move from an NSAID to the next stage of a medication?
Well, let me start by saying that in my very extensive experience, including having a cohort of nearly 1,300 AS patients, the SOAS cohort that we've been following for over 20 years, that 50% of patients with axial spondyloarthritis or ankylosing spondylitis can be well controlled with non-steroidal anti-inflammatory drugs alone.
Wow.
50%. But about 50% won't be, and they're the ones that are going to go on to some of these other medications, some biologic medications, some other medications called small molecule inhibitors, or in those patients who have just mainly disease in their joints, drugs like sulfasalazine.
Okay. So what are the goals as you're treating someone for spondyloarthritis and the different medication classes?
Well, the number one goal is to control inflammation, because that's what drives the disease, and associated therefore with that would be controlling also the pain and impairment that the patient feels. Another important goal is to get the patient able to function better, improving functional impairment that is associated with axial spondyloarthritis, ankylosing spondylitis. And then thirdly, to prevent structural damage, i.e. fusion of the spine or destruction of the joints.
So talk to me a little bit about we talked about NSAIDs, then you've got biologics. What other buckets of medications do we have?
Well, as far in the biologic category, but not biologics, are drugs called small molecule inhibitors. The one that is most commonly used and been approved by the FDA are the Janus kinase or JAK inhibitors, and there are currently 2 JAK inhibitors that are approved for treatment of axial spondyloarthritis, and that is Xeljanz as well as Rinvoq.
And what do the JAK inhibitors do that the other medications previously couldn't achieve?
Well, each one of the groups of medications, the two kinds of biologic medications, they target specific molecules in the immune system. So the anti-TNF medications, which are the ones that the biologics that were out first, will target the tumor necrosis factor. The IL-17 inhibitors will target interleukin 17. And there are currently 2 and soon to be 3 of those that are out there. And then finally, the JAK inhibitors they're different than these because each one of there are actually lots of JAK inhibitors that are under development, but there are 2 that have been approved. And there are 4 different kinds of JAK molecules: JAK1, JAK2, JAK3, and another JAK inhibitor called TYK2, tyrosine kinase 2. And each one of those 4 are targeted in a lesser or greater way by these various JAK inhibitors. But what's important to know is that unlike the TNF inhibitors and unlike the IL-17 inhibitors, each of the JAK inhibitors will actually targets the JAK pathway in a slightly different way. So each one is sort of unique in its approach.
So a different way to get down the road.
Exactly.
Okay. Beyond the goals for treatment, do people experience side effects, and what are they from some of the medications, and how do patients go about managing those side effects?
Like I said, I've been around for a long time, and when I was a young doctor, and when all we really had to treat spondyloarthritis were non-steroidal anti-inflammatory drugs, I very, very frequently was seeing patients admitted to the hospital because of gastrointestinal bleeding ulcers, gastritis, and the like. Of course, we've had now medications, the H2 blockers, the proton pump inhibitors that have almost wiped that out. They've made that very, very rare. But gastrointestinal bleeding was one of the most noted side effects of non-steroidal anti-inflammatory drugs. There's also a controversial weak-linked cardiovascular disease in non-steroidal anti-inflammatory drugs. And in fact, people with established or bad cardiovascular disease probably should not take non-steroidal anti-inflammatory drugs. Also, people with kidney problems, whose kidneys may not be working very well, non-steroidal anti-inflammatory drugs can actually make the kidneys work less well. When we get to the TNF blockers, of course, all these newer medications really suppress the immune system, and so you worry about infections. And so with TNF inhibitors, for example, you worry about tuberculosis or other mycobacterial diseases that relate to tuberculosis, such as atypical mycobacterial infections, or even leprosy, which is another mycobacterial disease, in which I have encountered in one of my patients who got a TNF blocker.
Oh, wow.
Yeah, well, this is East Texas, so leprosy is endemic here. They're not going to get anywhere else in the United States. With IL-17 blockers, with a particular note is that they can be complicated by fungal infections. And JAK inhibitors, the infection we worry the most is shingles, herpes zoster, and JAK inhibitors can trigger that. That said, so each one of these different groups of medications have different infectious problems that we worry about. But on the other hand, we can be vigilant. We can screen for those up front. And I've run the county HIV clinic for the past 30 years, and I use all these drugs in patients with HIV who have spondyloarthritis without any concerns.
That's amazing. And are there some mild short-term side effects that people might experience when they start taking a new medication?
Well, again, it depends on the medication, but I know injection site reactions, like some inflammation around where the patient injects the medication, is a noteworthy one. Some of the drugs that were particularly noteworthy to cause that, salts such as adalimumab, which is Humira, but now biosimilars are coming out, or Taltz, which is ixekizumab, have been reformulated, so that is a significantly less problem. But that's one notable thing that we might see. Those are probably the main ones. There's increased frequency of colds and the like with that. There are concerns with TNF blockers about a possible increase in skin cancers, not the melanoma kind that can kill you, but the regular skin cancers you get being out in the sun. There's a slight increase in that. And then there is a questionable, and I mean really questionable, link of TNF inhibitors to lymphoma. To other cancers that we just have not seen it. And even in with the link of TNF blockers to lymphoma, it's primarily seen in patients with rheumatoid arthritis. With the IL-17 blockers, we're not aware of any link to any cancers. Same can be said for JAK inhibitors. Of course, the one concern about JAK inhibitors is whether or not there is an increased frequency of blood clots with that.
But in general, is it safe to say the evidence points to the medications for spondyloarthritis being generally safe for most people?
Resoundingly safe and well tolerated. Resoundingly. I mean, in fact, my patients who, for some reason, were scared to take it and finally did, they usually say, "Why did I wait so long?" So if they need it, they should get them. Look, just like in my patients with rheumatoid arthritis, these are different diseases today than what I was encountering 40, 45 years ago. When we saw a lot more fused spines. We know that, for example, the use of TNF inhibitors can slow down the rate of spinal fusion. We know that, and other radiographic damage. So if you're in that 50% of patients with AS who will need more than just a non-steroidal anti-inflammatory drugs, which, by the way, in themselves, at least some of them, seem to slow down spinal fusion. But if you're in that 50% who needs more than that, you should really go on to these drugs.
Yeah. You just made me think. I was on vacation last week and I was sitting on the beach talking about SpondyCast with someone I randomly met. And I said, "Well, I do have spondylitis." And the first thing she did, she was a physician. The first thing she did was she paused. She turned and looked at my back. And she said, "But you don't look like you have spondylitis. And I didn't think women really got spondylitis."
Well, it's true that this is a sexist disease. Right? Yeah, but it's sexist because women are equally impaired and have as much disease activity and pain as men do, but they are much less likely to go on to spinal fusion.
Yeah, but my thought was I probably don't have as much damage as I might have had I not started taking my own version of my own treatment course. Okay, so interactions with other medications and supplements.
Oh yeah, well, I'm glad you had. Yeah, so I'm not a big fan of supplements, but I do take my turmeric gummies every day. They're delicious, by the way. You don't take turmeric with your biologics because it's the only supplement that really does anything, that's been shown to do anything. And one of the things that it does, it'll block the effect of your biologics. So if you're taking turmeric and you're on a biologic, like especially a TNF blocker, stop the turmeric. Okay, that's a big important thing to note. Now, interactions with other medications. There is some issues with JAK inhibitors and vaccines. You need to stop the JAK inhibitor 1 week before you get any vaccine, by the way. 1 week before you get a vaccine shot, and for 1 week after. Otherwise, the effect of the vaccine will be blunted. Certainly, there's all kinds of side interactions with non-steroidal anti-inflammatory agents and a variety of medications, most notably with anticoagulants. There are concerns, but I think we're moving beyond that about combining biologics. But I think people are doing that more and more now. The little data that we have suggests that on the one hand, there's no added safety signals by doing so, but on the other hand, there's also no real evidence of added benefit.
Huh. Okay. That's an interesting one. We'll pick that one for another one because I'd like to explore that. Do you see there are common misconceptions or understandings about some of the treatments associated with spondyloarthritis?
Um, I think people get too worried about the fact that their immunosuppressive nature as well as the link to cancer. And first of all, there is no link to cancer. I've had a number of patients. We're in Houston, and MD Anderson Cancer Center is right across the street from us. And when we get patients who are on TNF blockers and come down with a cancer for other reasons, and they go to MD Anderson, they never stop the biologic, okay? Because I even one patient who was on TNF blockers for years did develop lymphoma. He was back on his TNF blocker within 4 months of his lymphoma going to remission. That was 10 years ago. He is still on his TNF blocker today, and his lymphoma never came back.
Oh, wow. Okay. That's fantastic, though, right? Hearing like the resounding safety, to use your word.
They're very well tolerated. They are somewhat immunosuppressive. Again, I use it in my HIV population, except for the very advanced patients, and have seen no difficulties. I've treated over 30 patients with these HIV patients with these, and so the effect on they're only weakly immunosuppressive. That's one thing that people are scared about when we're talking about doing it. Of course, there's the whole expense issue, and that's we you can say that's for another program, but the cost has gone way up. Humira, when it came out in 2005, was $15,000 a year. Now it's $60,000 to $80,000 a year, and really all the other drugs have followed suit.
Wow, that may be a whole nother episode or two. So let's talk a little bit about benefits and risks. So NSAIDs, we talked about.
Heart disease and kidney disease are always concerned. The whole issue with Vioxx in 2004 was basically a house of cards, because the link to heart disease is very weak there. The drug should have never been pulled, and a lot of patients were very hurt by that happening. There's a drug that's used everywhere else in the world called arcoxia, otherwise known as the toricoxib. That is a specific COX-2 inhibitor that's very effective. The only one that we can get in this country is celecoxib, which is the Pfizer version of that is known as Celebrex. And there's a weak link to heart disease, and we don't want to use those in people with advanced heart disease. We also don't want to be using those medications in people who have borderline kidney function, because they can make things worse, although it's only a transient effect. And of course, they can still cause GI upset. Probably the most frequent reason for discontinuing non-steroidal anti-inflammatory drugs is the fact that the patient had a lot of GI upset with it. With some of these other medications, with TNF blockers, like I said, the main concern would be a link to infection. I have a couple patients who have ankylosing spondylitis and lupus both. You would not want to use a TNF blocker in that setting, because the TNF blocker can actually make things worse. Also, patients with heart failure, you got to be very cautious about giving them a TNF blocker, because that can likewise make the heart failure worse. So those are concerns as far as TNF blockers are concerned.
Okay.
With the interleukin 17 inhibitors, they may actually worsen patients with Crohn's disease or ulcerative colitis. And so we use those drugs with extreme caution, the IL-17 inhibitors, and patients who have that. I've already talked about the venous thrombosis issue in JAK inhibitors, and I think a patient who has a tendency towards that, you're going to be very careful about that.
Okay. And then in terms of the different styles of medications, how long do they take to start working? And
Virtually, the biologics, virtually overnight. It's virtually overnight, but we tend to see the full effect within 4 weeks, but they work very quickly. That can be said for the TNF, really with all of them. Within 4 weeks, we are definitely seeing an effect, almost full effect by that stage. But you tend to see the effect of the medications right away, especially for the ones that are infusible, like infliximab or golimumab, the ones that are given IV. I mean, we see effects within hours.
I would concur on my own experience. And what about, so NSAIDs obviously work pretty quickly on the pain piece. Are NSAIDs something you'd want to continue taking on a regular basis, or just when you have pain?
If you have active, we know that if you have active AS, that patients who take NSAIDs on a scheduled basis, let's say they're taking a leave, which is over the counter. They should be taking it twice a day. I usually have them take 2 more tablets in the morning and 2 tablets at night of a leave. And we do that with the disease active. If the disease is not active, taking them on an on-demand basis, i.e. when the patient feels a little bit less well, is perfectly acceptable. And in fact, within the guidelines that we use.
Okay. Are there any general do's and don'ts when it comes to medication use?
Well, that's a good question. Try to take them as prescribed, obviously. Now, sometimes we need, for certain patients, especially, for example, those that have inflammatory bowel disease like Crohn's disease, where they have to take a little higher dose or more frequently than we ordinarily would. But for the most part, you should be taking them as prescribed. Some people, on the other hand, try to taper them out, and they often don't have such a good effect there. Certainly, it's not a good idea to inject your medication right out of the refrigerator, because you want to let it warm up for about 30 minutes, because it's going to hurt a lot more if you inject it cold. On the other hand, don't leave it out for too long, or it'll lose its effect. So that, just about a half hour is a good amount of time to leave it out. The JAK inhibitors are pills; they aren't injections, so they don't matter. They're going to be in your medicine cabinet.
Okay. Any other do's and don'ts?
Again, make sure you're injecting it the right way. A lot of times, some people prefer a pen where they just press a button and it injects itself. Some of my patients prefer the syringe. They claim that they don't have as good control when they use the pen. I know the first time I was demonstrating the pen on a patient, I pressed the wrong end.
Oh, geez.
I know, sore thumb.
Yeah.
So you do want to make sure you're injecting it the right way. I think those are some of the key issues. Take it as prescribed. Let it warm up before you inject it, and try not to run out, because because that can be a problem with this major disease flare. Most patients, unfortunately, who stop their biologic are going to have a flare, 70% at least.
And is there a point, so when patients begin a medication or change medications, is it good practice for them to track symptoms and progress, or?
Absolutely, because we want, there was actually I was part of a panel that did a treat to target mode of treating spondyloarthritis, and that approach is not favored, however, by the American College of Rheumatology SAA treatment guidelines. When they reviewed the literature on that, they didn't feel there was good evidence for that. But nonetheless, that is to try to have complete control of inflammation, including pain, and maximize functional improvement and the like. If you're not getting that, then you may not be on the right medication, or there may be other things that are causing that. Just because you have spondyloarthritis doesn't mean that you can't rupture a disc, or it doesn't mean that you can't have also osteoarthritis in your spine. In fact, most patients who have AS over time are going to get also some osteoarthritis, which gets things a little bit confusing. But the symptoms are different, because AS pain is inflammatory pain, so it's morning stiffness, pain that improves with activity, whereas osteoarthritis pain gets worse with activity, not associated with morning stiffness. And NSAIDs don't work so well, I guess.
So if you have a patient come in who started a new biologic or DMARD, and they came in, they said, I don't think this is working. What would you look for, and how can they communicate that best with not only you, but other healthcare providers or other rheumatologists they might have?
Well, one thing is the pain hasn't gotten significantly better, and specifically the inflammatory pain. Again, you always have to distinguish if the pain is coming from the AS or there may be another cause, because one of the most frequent reasons for treatment failure is there's something else going on. So yeah, that's the first thing you have to say, is the pain coming from AS? Blood work can help you somewhat. We have inflammatory markers. It's not perfect. We're studying to see if we can find better biomarkers, but the C-reactive protein or the sed rate are the two best biomarkers that we look. And if the CRP is persistently high and the patient's having symptoms, that's an awfully good sign that they're getting inadequate disease control with their medication.
Is there a rule of thumb on how long to stick with a medication before trying something else?
Yes, the guidelines are at the most 12 weeks, but frankly, if I haven't seen any benefit by 6 weeks, I will generally pronounce that patient a treatment failure.
Okay. With all this, you mentioned there's a number of new drugs in development. How can people get involved in research, whether it's becoming part of a clinical trial or better understanding what's coming up?
I think the SAA website will give you a lot of information along those lines, because it all depends if your rheumatologist is really follows the progress in spondyloarthritis. We've done an incredible job with all the new medications that have come out, but we're still not controlling not getting adequate control, very excellent control in about a third of patients. And so we welcome the new drugs coming out. I have seen patients who, for example, don't respond to one group of medication who do very well on another. To be honest, that's more the rule than the exception. If someone hasn't responded to one, usually they'll respond to something else. And if they're responding to nothing, the first two things you have to do is question if they really have AS. Sometimes it can be a little bit, the diagnosis isn't always as straightforward as you like. And B, if the cause of their pain is indeed coming from spondyloarthritis, or perhaps coming from other causes such as herniated disc or spinal stenosis or osteoarthritis. Or worse, as I've certainly seen, like an infection in the spine or a fracture.
So let me ask you this. You've got a nice time set. You've been involved in this for long enough. Do you see patients from different demographic groups responding better to medication as they've been including more demographic groups in clinical trials?
Well, I would say we were having that conversation before you got on. The African Americans and Africans in general with spondyloarthritis have not been well studied, and so that's a real issue. I was president of the Pan American League of Affiliated Rheumatology Societies. One of the issues that we were dealing with then is clinical trials in Latin America being complicated by a very high placebo effect, I think that is an area that needs a lot of study. Most of the clinical trials that are happening these days are taking place either in Eastern Europe or in Asia. So I guess I don't have any good. I don't have a good answer to that particular part of the question. But then we get into gender, and women, as a rule, do not respond as well as men, either in clinical trials or clinical practice. Why that is not clear, but it's one of these disparities that we deal with this disease.
Interesting. I'd love to unpack that some more someday. This has been fascinating. I want to ask you, is there anything else you think is important for people to hear in this community? And
Well,
go
I
ahead.
think having an accurate diagnosis is imperative, and I think more and more an accurate diagnosis means getting an MRI. Unless you already have structural disease that shows up on an X-ray, getting that pelvic, not lumbosacral, pelvic MRI early on, because once you go on, because the thing that drives me crazy is when I can refer to a patient who has already been been on biologics. They're not doing well. There no MRI imaging was done early on, and the X-rays are negative because once they go on a biologic, that MRI is altered forever, and so those patients, I can't even if they're B27 positive, I can't be 100% sure they even have the disease if the X-rays are negative and the MRI when I get it is negative. But like I said, if I haven't seen an MRI before they started biologics, all bets are off because the putting a patient on a TNF inhibitor will alter that MRI forever.
How so?
Again, not been well studied, but we find that it can cause the bone marrow edema to go away. In fact, it usually does. And then later on, if the pain is coming back, the bone marrow edema might not necessarily come back. That's why I always try to get an MRI early on in the course of the disease before they go on biologics. Because if that hasn't been done, they've been put on a biologic without an accurate diagnosis having been obtained. Now, if they have obvious X-ray disease, then that horse is out of the barn and is running down the road. In this situation where there was two, classically, you remember 7.5% of the white population in the United States is HLA-B27 positive. Okay, only about 1.5% actually have axial spondyloarthritis. So in other words, 4 out of 5 will not have axial spondyloarthritis who are B27 positive. Yet there's still a tendency, especially among non-rheumatologists, but even among some rheumatologists, if they're B27 positive and they're having pain, they treat them with biologics without getting the appropriate imaging studies or even other diagnostic studies.
Oh, what a shame. Other than that, my big question is always, based on your experience, what do you find hopeful about the future for people with AS or spondyloarthritis?
Well, I earlier diagnosis, more accurate diagnosis, and I think those tools are coming. Biomarkers are being looked at. Things like what we've already published, which is looking at a genetic profiling risk score that may in a patient who's having symptoms help to with the diagnosis with better imaging techniques, which perhaps PET scanning and the like. So should help us get to this disease. We know that the earlier we treat, the better the outcome and the less likelihood of fusion. So I think as far as a cure is concerned, I don't know. There's a lot. We're doing an incredible job with certain diseases of curing them, but mainly it's infectious diseases. I don't know if we're going to get to the point where we can cure AS, but we sure are heck of treating it a lot better. And that old picture of the Canadian World War II veteran, where we saw progressive spinal deformity over the years, that's a thing of the past. And we just do amazing things for patients with this disease now, including hopefully to keep the patient in non-radiographic disease, to keep radiographic disease from ever even developing.
Yeah, I love it. Thank you so much for your time and all the work you do in this community, and also for the work that you do in the HIV community. That's really important work, and tying those I'm sure when you have HIV plus spondyloarthritis, it's just an extra load on you. So
It's been I wrote my first paper. I wrote my first paper in a non-PubMed journal on HIV in September of 1981.
oh, wow.
Yeah, the very beginning. And my first published peer-reviewed paper was in 1990. That's looking at spondyloarthritis, so psoriatic arthritis, and we called it Reiter syndrome back then in the setting of HIV. And it's been a real. I've written many papers and book chapters and the like since, and that's been an interesting road. But it's not my primary focus. My primary focus is spondyloarthritis and the genetics thereof.
And we are grateful that you took this path in life. Believe me. Um, well, I'm going to let you get back to your day, and I'm sure go help someone else. But thank you so much for your time, and
Surely,
I
I,
will I will see
I,
you in September.
I'm meeting with a student on an AS project later this afternoon.
Awesome. Excellent. All right.
Good talking to you.
You too.
Okay.
SpondyCast was made possible by donations from the Spondylitis Association of America's individual members and our show's corporate sponsor, AbbVie. Since our founding in 1983, the Spondylitis Association of America has been the face, voice, and leading nationwide nonprofit educating, empowering, and advocating for people living with spondyloarthritis. Through our extensive work with patients, the medical community, and partners, we provide information and resources to help people impacted by the disease live better lives and champion research to find a cure.